Hi doctors, thanks for coming. I'm Sarah, one of the nurses.
I'm Peter, one of the doctors.
Hello, Daniel. Hi there. Kelly, the doctors are here now just to see you. Oh, he's just been in severe pain. Okay. 3-day history of
Just
pain.
need some painkillers,
I know, sorry.
What painkillers have you got?
What? He's had paracetamol about half an hour ago.
Alright, I'm just going to prescribe a set of Oromorph for now.
Oromorph, do you want me to put cannula in then?
Oromorph is oral, but I think it would be worth getting a cannula
Just,
in anyway.
yeah. Okay. So, right, so you want me to give some Oromorph as well?
Yeah, just 5 milligrams for now.
5 milligrams.
We'll see how that does. Hello, Kelly. My name's Avita, I'm one of the doctors.
I can't handle it.
Okay, we're going to get you some pain relief. Okay. Is the light hurting your eyes?
Yeah.
Okay, just keep them closed for me, that's absolutely fine. Okay, do you want to maybe start an ATV assessment? I'll try and get a bit of history from him. How long has this been happening?
A couple of hours.
Couple of hours? And did it come on suddenly?
Yeah.
Really suddenly? Did you fall? Did you hurt your head at all?
No.
What were you doing?
I think I was just on the toilet.
Just on the toilet. This came on really suddenly. Okay, I'm right here. Okay, let's get that pain relief. So everybody's beaten.
Oromorph, yeah.
What did
No, it's alright. I'm just looking for a medicine pot.
So if you get started on an A2E, please, Daniel. I'm just going to get a bit more history from the notes.
Sorry, so
Jimmy, no, it's
can
all
I examine you a bit?
All this history is there.
Examine you
It's
and
got a
see
lot
how
of
you
rest
are
today.
doing. Okay.
Confusion hearing, no
Okay.
facial
Alright.
weakness, no headache or facial pain.
Calm down.
Steady.
Just going to give you some medicine.
Oh.
Can you swallow it?
What is it?
Just strong painkillers.
Okay, so he does have a past medical history of migraines.
Okay.
Kelly, do you take anything for migraine?
Yes.
What do you normally take?
I use a beta blockers or something. This doesn't feel like migraine.
It doesn't.
No.
Kelly, I'm just going to pop this on your arm.
Okay.
And have you been sick at all?
Yeah.
Any aura?
I feel sick.
Have you had any aura at all?
I wanted him. I don't know what.
Not heard that before?
I haven't had any of the lights.
No lights or anything, you just came on all of a sudden. Okay, I think I'd like to get a CT head for you just to check that nothing's going on there, if that's alright. I'll order one of them now.
Do you want me to put a cannula in then?
Yes,
Do you want me to take some blood?
That's okay.
What blood do you want me to do?
If we can just get that full blood off,
Use LFTs.
just all the regular monitoring bloods.
Yeah.
If we can get a coagulation screen as well.
Yeah. Yeah.
At the minute, I think
Can
everyone
pain in your way?
might have had hemorrhage.
Can I touch it, Sunny?
Possibly it came on and worried about subarachnoid.
Okay.
I know the gold standard for that is an LP, but I think let's try and arrange for a CT head in the meantime. Do we have a fundoscope here then?
Are you okay? How's the pain after the morphine?
Pen torch.
Hello? How's the pain after the morphine?
That's all you're gonna get.
Okay, that's absolutely
For
fine.
the pain, okay, with the
We
morphine?
don't have them on this one. Sorry.
Has that helped at all, Daniel?
No, I think the pain, the morphine didn't help with the pain.
It didn't help at all. Okay. Can we just make sure the lights are nice and turned on here? Because I think that might be setting off.
Turned on or turned off?
Down.
Down.
Just down.
Yeah.
You still need to be able to see.
Okay.
Right, this might be uncomfortable, but I'm just going to have a quick look in your pupils with the light, okay? Pupils equal and reactive. So with how suddenly it came on, the number one thing that I'm worried about is a subarachnoid hemorrhage. He does have a history of migraine. It is possible that this is a very severe migraine with the photophobia. Hello, Kelly? Can you hear me? Okay, it's becoming a little bit less, just let's put out a neck call. But with the photophobia.
Do you want me to get this line in?
Encephalitis, meningitis as well.
Kelly, I'm just going to pop this.
Okay. Right. Kelly, can you still hear me? Okay. Yeah, if you put out the medical, I'm just going to get a full set of odds here. And I'm going to repeat that 82E assessment. Kelly, can you hear me at all? I'm just going to give you a really tight squeeze on your traps, okay? A little bit of response to pain. Okay.
Right,
These are the obs, I'm assuming.
just and then that was
Pulse is regular, it's slow, obs are okay. Can we just get an ECG for it as well when we get the chance?
Yeah, I want to put it in
Right.
Blood pressure is really, really high, which could be a sign of a hemorrhage. And have we got any news on that CT head as well?
CT head.
Is it?
They're just it's just on the floor.
Corporate patient I'm seeing at the moment. We are acute medical unit at the moment.
Hey, can you hear me?
Acute medical unit.
Okay, this could be a little bit of the morphine making you drowsy, but it could also just be a sign of a hemorrhage.
Okay.
Okay,
I'll send
so
them
if you
off.
can. Okay, let's repeat that blood pressure. Okay, so blood pressure is going high, pulse is low, so I'm a little bit worried that it might be a serious subarach. We can't. I think we're still waiting on the CT head. In the meantime, should we call the med-reg on call and see if we can get them here to discuss? Is there any other thoughts that you have or anything else that you'd like to do? Okay.
So are you calling the med-reg? Yeah, okay, and it's just that button.
Okay. Is airway still patent?
Yeah, I know one of the F2s I want to see.
Okay, his respirator is slowed right down, so could we change that med call to a crash call? I'm a little bit worried.
Do you want to put a crash call out?
Yes, please.
Can you put a crash call out?
Yeah.
Okay. Hello? Yeah, hello.
Okay, I'm just going to repeat these obs now.
AMU at the moment, we are seeing the patient.
And I've got a stethoscope.
Can you?
Hello?
Really slow, shallow breath.
Yeah, hello?
I'm just going to press in the tummy.
You can hear me?
Any
Yeah, so
pain
we
at
have
all?
a mark
Kelly, can you still hear me? I'm just giving you a big squeeze.
Severe.
Still responsive to pain.
Sorry, his name is Kelly Forrester.
Kelly?
50-year-old female.
No, that's it. Okay.
Would you be able to go on a different method?
Presented with dizziness and also
I'll put a crash call out.
was
Yes, thank you.
delayed. He has no facial weakness or no headaches at the moment.
Okay.
There's no trauma and there are no respiratory symptoms. No. No, his currently having severe headaches, which is sensitive to light. Currently there is
I've asked for more help to come along.
Is that a crash call?
Yeah.
The pulse
Yeah,
rate is
brilliant.
60
Thank
and
you.
the BP is around
Okay, at the minute, the
197.
patient's only responsive to pain. I'll
Currently
wait
it's
till
not
Daniel to
responding.
finish handing over. And then let's have a
Yeah,
the
it's not responding.
debrief.
Yeah.
I've just
Yes,
put
we put
out
them
a net
on-
call.
they are on.
And then in terms of that
Okay.
CT head,
Wait.
I don't imagine it's being done. So I think right now we need to just focus on
Okay.
making sure he's got a good airway. Is he still breathing? Yep, airway is still patent.
Not yet.
We're repeating that blood pressure.
Yeah. Yeah, so for
Okay,
now we are
pulse is
having
really low.
some hemorrhage on our differential top.
Blood pressure is rising and pulse rate is dropping. So if we can just get here as soon as we've just got a crash call out.
Okay. Sorry, I didn't the bit, the last bit.
Met calls on its way.
Is it with the
Okay,
anaesthetist that
okay.
the crash call is coming?
Okay.
Brilliant. Okay.
Yeah.
Okay, you can still hear me, right?
Alright. So the midwife also wanted to put to anesthetic because he may arrest.
So we've put an arrest call out, the anaesthetist is on the way, med-reg should also be on the way, I think. We've not got any imaging done of the head yet. He's just responsive to pain. His pulse is now 47 and his blood pressure's gone up to 201. I haven't been able to look in the eyes because I don't have a fundoscope. Is there anything else that you'd like to add just while we wait for that crash call? I'm just going to keep repeating that A to E in the meantime.
So what's happening?
Do we have a protocol for subarachnoid hemorrhage?
We can have a look on here. So what's the plan?
So at the minute, I think he's having a pretty large hemorrhage in the brain. I can't confirm what kind of it is because we don't have a CT. However, his blood pressure is rising and his pulse is dropping. So I'm a little bit worried this man could arrest. That's why we put out a crash call. If we have a protocol for any brain hemorrhages, that would be brilliant. If we could just have a look at it.
Okay.
In the meantime, we're just waiting for the med-reg and repeating the E2E assessment.
Okay. We're waiting for that now. Okay, so I think, right, have you got the patient's details up there?
Hello, I'm Olivia. I'm one of the
my name's
graduates.
Vita. I'm one of the SHOs. I'm really worried about this gentleman.
Gosh, yeah.
He's got a history of migraine, but he's presented with a very atypical headache, which is much worse than usual.
Yeah.
Since then, his blood pressure shot up and his pulse has gone down. It was very sudden onset. I'm worried about subarach. We've not been able to get a CT head. I've not been able to look in the eyes.
No, he's too unwell, isn't he?
I'm a little bit lost on what to do, to be honest.
That's
so
fine. I think we need anaesthetics. I think this man
So we've
might
put out
be
a crash
coding.
call, so I imagine that they're on the way.
I think we're going to need to intubate this man for a CT. It looks like he might be starting to coma with that, with
Okay.
those signs. I think you've done a great job, and we will leave it there.
Yeah.
Oh, they're so different all these scenarios. You're like one just talking and the next just like you and this stuff. How was that?
Not very nice.
It wasn't nice, but how do you think it went?
I think the good points first. I think me and Daniel, right before we even went in, we talked about like who was going to do the A to E and who was going to do the history. Once my role in doing the history was sort of up, Daniel kind of actually took the lead and like went onto the phone, so I just kind of carry on with the A to E. So we did kind of switch roles there, but I think it was quite good how we kind of coordinated that amongst ourselves.
Great. What else? Anything else that we could do?
Really nice deterioration.
Yeah. I think that was really good actually. You like reset us. I think you did like 3 ATEs within that 10 minutes. I don't even know if you realised it, but you kept going back and reassessing and noticed the deterioration was really good. Anything else?
I think it would help.
Yeah. How appropriately, didn't they? What was good. I thought your communication was actually really good. I think the nurse knew what was going on. I don't know whether anyone noticed when you had done your history and reviewed the notes, you stated really clearly, I'm worried this might be a subarachnoid hemorrhage. The things I'm worried about are this, this and this.
Yeah.
But this is my main worry. I'm going to go and reassess, and that's when you notice the deterioration. So I thought it was very good. What was challenging though?
Honestly, it was a bit of a knowledge deficit on my part. I normally just sort of get a protocol up on EPR, and then when I didn't have one like in front of
It
me,
was me. Yeah.
I was like, oh my god, I don't know what to do. I would just call for help. Like that's all I could really think to do in the moment. I didn't want to do anything that would sort of compromise him or like make things worse as well.
I think that's okay. I'm sure many people in this room can feel that kind of panic when something happens they don't know. That's why we're F2s and not consultants, you know.
So I think
Like,
asking for help is completely appropriate in this
Agree.
scenario where the patient is deteriorating. So you did the right thing.
Completely.
Because you alone won't make him better.
Yeah, that is true.
Absolutely.
Yeah.
Absolutely. Spot on. Anything else? Do you find anything challenging?
Yeah, I think the whole scenario was kind of challenging at the beginning. Since I was a bit lost with it, and then she helped me up with the differentials and those things.
Yeah.
And I didn't have the history to clearly, so when I was making the call, I was kind of lost a bit where the patient will also have to go through to find out the patient is ANU.
That's what I was thinking because like obviously Daniel didn't get the history like written out in front of him like I did, so I think I could have maybe communicated a little bit quicker with him just to let him know like okay, this is what I'm really worried about right now. But I think you did a really good job. I heard little parts of the SBAR and I think it sounded really good. I think the med-reg knew exactly what you were worried about.
Because the first we put out was actually a MEC call and then a rest call, wasn't it? So you don't even need to know much, do you? You just need to know, what do you need to know when you put out there?
Where you are.
Where you are. I think that's literally the only thing you need to know, isn't it? Where you are and what you want. Is it adult crash call, is it obstetric crash call, paediatric crash call, what is it? That's the only thing you need. And then yeah, you did have the SBAR. So you found I don't necessarily agree with this, but you said you found the knowledge was the bit that let you down of subarachnoid. Is that right? Is that what you mean?
I mean, yeah, just like in the moment, I think I always do this in a sim. My brain just goes a little bit foggy. I'm a bit like, what do I need to think about right now?
But you got the diagnosis. Or like you got the main thing, which was like some sort of cerebral vascular accident. So I'm not sure what the knowledge deficit was. You got there.
So it just felt I didn't feel sure of myself in the moment.
Sure.
And I think with the migraine as well, I think it links back to what Will was saying at the start about like not wanting to have that
Affirmation bias.
affirmation bias. A big part of me, I knew it wouldn't because it's a sim. I was like, I really want this to be a migraine.
Please just let me get the Subarachnoid 10 out.
But
For this page.
yeah,
900
aspirin, imagine.
And I guess I understand what you mean in a sim. It's stressful. You don't know what's going on, and you say you don't want to have that where you're like, please just be a migraine, whatever. But how were you going to know what was going on?
Investigation.
Yeah, investigations. And you requested that. You asked for help immediately, and that was going to come. I think what was really good, what was important, was to notice the deterioration, which is what you were mentioning. What do you think was going on? Why was?
Yeah.
Yeah.
Cushing's triad, wasn't it? Yeah. Raised blood pressure, bradycardia.
What was the third bit?
Oh,
No GCL.
low, yeah.
So, which can affect your breathing, so you get breathing. So I think
Which
that
he
was
was doing
which is
really
what he was
well,
doing.
really convincingly. I was a bit like,
Don't worry.
hello.
Do we know, if we do just briefly talk about subarachnoid hemorrhage then, like what are our investigations of CT head? How quickly?
As
fast as
possible. As soon as
Yeah.
the patient's stable enough to go to CT, really.
Was he
I
scheduled?
should have rang them probably actually after requesting it and being like, this is what I'm worried about, can you get him down now?
Yeah. But would you have wanted him to go to CT?
Not in that state, no.
So who would it have been better to ring to hurry along?
Yeah.
He's going to need intubations and stabilise him before you can scan him. So actually, we've got kind of past needing to know what's caused the deterioration and just get him out there to manage the deterioration. So CT head. What if he wasn't quite so sick, but you thought he had subarachnoid hemorrhage? What's our window?
4 hours.
Does anyone know any of them?
Within 6.
Yeah, I've got the guidelines here, same reason I know. So it's within 6. So
6
you
hours.
should 6 hours within onset symptoms. So if someone walked into urgent treatment centre and had it for 3 hours, then. If that CT head is normal and you've done it within 6 hours, what do you do?
LP.
And how convinced you are of the
No, it's
history.
mean. The guidelines have just changed really recently, like at the end of last year. So if your CT is performed within that 6 hour window and is negative, you shouldn't, LP, you should think about alternative diagnoses.
Oh wow, we've been LPing
We've
way
been
too many
LPing,
people.
I know, I was like, whew.
I thought they could
Interesting
LP
knowledge.
after 6 hours.
Yes.
They,
so-
they LP everyone only with the slightest headache.
So what's that then? What are they doing there? It's
Looking
what?
for xanthochromia.
Yeah, so they're looking for xanthochromia. So it's if they come in with a headache and you haven't managed to do your CT in those 6 hours,
Then you
or
do the
actual
LP.
CT.
Okay.
No, you still do your CT
CT
first.
first and then.
You can have
And then
an ongoing bleed or something for up to 2 weeks.
Yeah.
I'll show you the new guidelines if you're interested, just because they have changed and I only noticed today as well. So this is the bit where if it's negative within the 6 hours, you don't need to LP. Is that right side? Oh, sorry, did you want as well?
Is it headache at time of when they present within the 6 hours, or is it when they start
Symptom onset.
Yeah.
Symptom onset. So if they've come in and I've had a headache for 2 hours, then we've seen 3 hours, we work 5 hours, yeah? Do you see
So
what I
then
mean?
it becomes very difficult to get it done within 6 hours
Exactly,
based
so
on
it's-
how
it's
they present and when they're seen in A&E and Oi.
But I guess why it's probably changed is if within that 6 hours the CT should have shown something. So if it's not, it's probably not a subarachnoid. We need to start looking at other things. Yeah. But you do your LP if it's after. You can follow the guide. I don't remember that. So that's just an interesting point I thought because I had your rule in my head because it's just changed. But anyway, it's got personal.
it's just subtraction and geography or
Yeah.
okay.
So anyway, this guy was obviously much sicker than that. we would have been wanting that we wouldn't be LPing him, we'd be wanting to get a CT, but we needed to stabilise him first, didn't we, which was important. What's then the management of subarach?
Surgery. Per hole.
Yes, surgery. Anything we can give in the meantime? Does anyone know what we can give?
We were discussing that during the simulation about
Is it amyloid?
IV, is it?
So all that blood
That's
pressure
all.
management I'm not giving, that's ITU.
Yeah.
Anything to do
Well, yeah, we would speak to IT.
Allergies, yeah.
So it's supportive care allergies, but there's something we could give on a board if there wasn't an ITU bed.
Dexamethasone, is it?
Spit me pin. You could give oral nimodipine if they're still able to tolerate. So he bit me again, so he wouldn't be able to do that.
Yeah.
But if we got before that, it helps prevent vasospasm and helps control bleeding.
Right, okay.
So if you were not quite at that stage, anything that's IV and stuff, you're probably all right. I don't know, but I wouldn't be doing that. That would be ITU because you don't want to bring that blood pressure down too fast.
Mm-hmm.
So you're going to need invasive blood pressure.
And the ISOP monitoring as well. Damn. Poor John.
He was really convincing.
Well, I was just saying you can put an outline in. That's
Oh,
a good bit of fun.
Anything like this, any raising to credit pressure again.
Do love putting an outline in.
Have you got one
As a med student, yeah.
Oh, yeah, I helped.
No, like you need to just sat there and like put it in. And I was like, yeah, alright. It's just the same as calculating. There's just a lot more blood.
So subarach, we worried about it. If they're stable, we follow that guideline. Unstable, anaesthetics, tube, get help. But I think you've done that, and that's where we were, wasn't it? You got the help. They were just the team was just being really slow. Anything else about that scenario that anyone was worried, or interested about, or curious about, or thought perhaps could have been?
Like, we were talking about analgesia.
Yeah,
I
we
think
we just bung that more and more thing pretty quick without knowing a lot about the patient's
What if he was
medical
allergic to
background.
morphine?
I've come off surgery. So allergies important. What else?
Renal function,
Renal function.
how much they've had already.
Yeah.
What they've
Had
had
that
already? Like,
internet.
have you had
Yeah.
paracetamol? Have
You
you
did
had
ask that.
Okay, I
They
didn't
did
say
say
that.
that.
Sorry.
But yeah, definitely allergies is important. What else with analgesia is important to think about in some
Drops the GCS as
Yeah.
well, on and off, so difficult to know if he's deteriorating because he's bleeding into his brain or because he's
That's true. I did say that as well when he started going. I realised and I was like, oh, that could also just be the morphine we've just given him.
It's pretty drastic the morphine to do
For
that.
fun,
But yeah, but it's important, and when people have headaches, it can be. There's no hard and fast rule, but it's that's even hard. Analgesia choice is important. Yeah, well.
Also, if it was just a migraine, morphine is not necessarily gonna help.
Yeah.
Less relevant, but
Anything else? This one didn't have much just really to debrief because I think it's headaches and subarach is and getting help. But have lunch. Go have lunch. Finish really early. I think they said 1, but we finished 15 minutes early. So the earlier we start, the earlier we finish. So maybe 1:45, half an hour long left for everyone. Or do you need longer than that?
I can't wait to sit and watch you all eat. I'm not actually, I'm not hungry yet. Ask me again when we finish and I'll see you